We have got Dr. Fagan. She is a haematologist with special interest in coagulation, bleeding and non-malignant haematology. And we have got a presentation on inequities in the LGBTQIA+. Welcome. She's got lovely blue hair.
Everyone, thank you so much for inviting me. I was just complaining that I spent the last 2 years trying to get equity talks in the hematology conference and how hard it is. And then to have a nursing conference that's just centered around equity is just so wonderful and so, yeah, it's just so uplifting. And it just shows where the leadership is in the room. When we did do a talk at Blood, the frustrating thing is I felt like we had everyone in the room was on board already. And I was preaching to the choir, and that's one of the really big issues. But I would just thank you so much. And I do feel like such an imposter after having Jason and May talk, because I have no research interest at all. The quickest way to put me to sleep is to make me do any research, as my supervisors for my my advanced training project will tell you. They had to drag me kicking and screaming to it. And if it wasn't the only thing between me and being a consultant, I don't think I would have finished it. But I'm really grateful. And I think this is probably one of the topics that, that little meme, like, what is a topic you could speak for half an hour unprompted, unprepared? Equity in healthcare is a thing that I will get on any soapbox at any point. So despite my imposter syndrome, that is why I'm here. There is some stuff that, again, I probably should have thought a bit further about how much you already have had so many talks about equity. But what I want to talk about is there is this new term that was called SOJEC, which I think I'm starting to get the lexicon, and it's about that not everyone goes, I identify as the L in LGBTQIA+. It's about saying actually humanity exists on a spectrum and lots of people have gender differences from the norm. And there's a little bit of racial stuff, but I think Jason has actually covered that fantastically. So I'll probably be quite small on that. There's a lot of these issues in hematology practice. A lot of it is actually in non-malignant hematology. There's a huge amount of stuff going on with normal values, like don't get me started on ferritin, and that because that's a women's issue. Like, if anyone wants to be on a working committee about changing the ferritin normals around New Zealand, please hit me up, because I am looking for passionate people to get this moving and to convince a whole bunch of people that is actually important, and that having a ferritin that is low makes you not good at everything, and that maybe we would improve people's outcomes. And I want to talk about the barriers of care, and what practices we can do in everyday life. I always put this up because whenever I talk, I guess Jason sort of touched on this, where it's like these ideas that people are getting more. And the fact is, the reality that we live in is that there are people out there who have, and I'm fortunate to be one of them, like I have a lot. I walk into a lot of medical rooms and I'm a doctor, I'm not queer coding, I'm ethnically ambiguous, and I don't get tarred by a lot of feathers that other people do. So I'm probably the person in that thing. I've got all these things that make healthcare is really easy for me. And there are people who are actually, they're not even anywhere close. And while equity is getting us here, oh no, it's not coming up. Sorry. While equity is getting us to, everyone's being able to see the game, what we want is no barriers. And the fact is, in my point of view, the point of equity practice is actually to help, while we're fixing getting rid of the fence, because that's actually the ultimate goal. We need to build people up so they're getting the people who aren't going to live long enough to see the fence go. And I also think I gave a talk to the medical students a little while ago, and we were talking about all the barriers, and it got really depressing. It really did, because we're talking to lots of people in the field and lots of people affected. And they said, well, what's going to happen? Like, how is this going to change? Everything we talked about. And I said, well, I have this story my dad tells me, and I think it might be apocryphal, but my dad tells a story. My mom is South African Indian. My dad is white. My parents got married illegally. My existence is illegal. My parents, if the government found out that my parents would be illegal, there would be legal consequences such as jail and deportation and me being put in a home. They lived in Lesotho. And they would travel back because my grandfather was ill, and they would lie constantly. They would have friends come with them. So my dad was actually married to the blonde in the seat next to him, and my mom was the nanny in the back, and there was all these lies. And one time my grandfather got very sick, and they were in the car, and they took 2-year-old me, and they were at a checkpoint freaking out that this is it. This is the moment they're going to get caught. And my dad said, "You might live to see free South Africa, but I never will." Because it was so entrenched. I was 12 when apartheid fell. Now, you can argue that there's still not equality, but I was 12. And I think the thing is, change is slow until it's fast. And that's the thing, when I talk about all the barriers and I talk about all of this, actually, it's about getting momentum and speed and getting everyone on board. And then it happens. The Berlin Wall fell in a day. So, and the other thing I always talk about, this is the other grounding thing that I have, is that everyone in one way or the other have gone into a room where we're not comfortable. And this wheel of power and privilege, if you're on the outside of this wheel, more of the rooms are uncomfortable for you. And I think just for that, for just talking about how we navigate, how people navigate health, this does it. Now, I went into a room with my father, who's a university professor. He is white. He is middle-aged. He was wearing a suit, because when you go to a doctor, you wear a suit. You don't listen to your daughter who's a doctor, but you do that. He is neurotypical, able-bodied, heterosexual, and he had neuro symptoms. And I had to fight to get my dad's diagnosis of Parkinson's. He is everything in the center of that circle. And all I could think about in that moment is, what the hell is happening to that man's other patients? That was the only thing I could think of, because I could advocate for him. I was like, "You're seeing my mate that I went to med school with. Like, can you write a referral to my friend? Thank you." And the other problem I find with this wheel is it's less so in nursing, but it's definitely present in medicine, is that most of the people who are providing healthcare are also in the center of that circle. So they have no idea. When I gave a talk about myeloma and equity to the Myeloma Summit, I had probably a dozen people come up to me like, "Gee golly, I'd never thought of that." I was like, "Have you talked to a patient? Have you talked to a Maori patient? Have you talked to a fat patient? Have you talked to a patient who is neurotypical?" Because they will tell you how hard it was for them to get into the room with you. And like, hematology is kind of easy because you get a biopsy, you get an abnormal blood result, and you come to us. But getting sometimes the biopsy, getting that result, that's where the problem comes from. So that's my little grounding of everything we're going to talk about. I have references at the end of this talk for all the things that I'm going to talk about. But basically, people who are gender and sexual orientation diverse experience higher rates of discrimination in healthcare. They do. There's data that says it happens. They also have negative experiences in healthcare with health professionals that make them go, "Yeah, I don't want to go see that doctor. Like, I don't want to go to that chemo suite. I don't want to go to that clinic because they out me, they misgender me, they never recognize that my partner is my partner." And so they get anxious about going in. So there's two sides of it, but part of it is it doesn't feel like a welcoming service. I wanted to put a little rainbow flower feather thing in my room, in my clinic room. I had this, like, I saw it. It's a mental health one. It just has like all the flags in feathers, and it's just a little thing, and it has written in it in Maori something like, I can't quite remember, it was something like, "You are welcome here," or like it was something like that. I can't get that through our poster committee. I could just put it up, to be fair, but I wear my pins. So but I was just like, this is ridiculous. And they're like, "No, it has to be official." And I'm like, "Yeah, well, how do I make it official?" "Well, you talk to this person." So I talked to that person. And then I got busy because I'm a doctor and I work in healthcare, and my patients get sick and everything happens. And I was like, "Oh crap, I still need to fight for that." But I want to do it officially because I could just put it up. Yes, I could. And I would, but actually I want to raise the issue. We know, and I'm going to present the data about the cancer disparities in cancer outcomes for Maori and non-Maori patients. I will tell you stories about institutionalized racism and inequitable equity. Well, everyone else can. I have a Maori patient who presented to Ashburton Hospital, and all I can think is, thank God she got a new GP when she moved to Oamaru, because she presented at Western Hospital with pneumonia. It was actually febrile neutropenia with platelets. A week later, her platelets were 13. She had bled into her brain in between. if you look at if you look at what you're supposed to do with myeloma, with pneumonia, you're supposed to do a full blood count. So yes, did she have typical presentations of leukemia? No. If you did the test that you're supposed to do, would you have gotten the diagnosis of leukemia? Yes. Do I think that there was someone with a mustache twirling his mustache being like, I don't like black people, and that's why she didn't get her healthcare? No, because that's not how racism affects our patients. The way racism affects our patients is a whole bunch of internalized biases that everyone has and they're not recognizing. So they're not doing quite as much as they should do. And even when we talked a lot about comorbidities, and they're incredibly important, but even when you correct for comorbidities, these differences exist. So the other thing I think is really important is I feel like when you're part of the, let's see, I still haven't got Sojix in my mouth yet. When you talk about that, it seems like they're an other. And in medicine, oh my gosh, it feels like it's one of the reasons I wear my little pin is I want the junior doctors to know that there are other queer doctors out there, that that it is a safe space for them. But 5% of adults in New Zealand in the last census identify as having a gender orientation other than straight. If you look at the total number of people who identify as not heterosexual, it is the same as the population of Hamilton. If you look at the people who identify as transgender, it is the same population of Cambridge. Now, Cambridge is a town, but it's not a terribly small town. And when we look at the people who identify as non-binary, it's as having in some variation of intersex, it's about 5%. That's as many people who are naturally redheaded. Just to give you some ideas about how many people you're coming across in your day-to-day life who identify somewhere on the sort of LGBTQIA plus spectrum. This is the depressing slide. These are the outcomes for this is excess mortality in marrying identifying people. And you can see that non-Hodgkin's lymphoma is definitely up there. There is 97% excess mortality in Maori patients. Leukemia doesn't do much better. And then obviously we have I'm not going to speak to the non-hematology cancers because I can say whatever I like, but I haven't done medical oncology for years. So some of it is the stuff we know. Some of it is the social determinants of health, which is thank you very much for that talk. Some of it is discrimination. Some of it is access to healthcare. If you're far away from a hospital, if you have no GP, you have no GPs in your area, you have locum GPs who aren't following I don't know if that's just a Southern thing. I think it's not. But like I have so many patients who do not have a GP. They have these amazing nurse practitioners who do their absolute best to service a community, and they may or may not have a locum GP every now and again, and it is terrible for patient care. And every time the nurse practitioners send us a trip, I'm like, anything you need, because you're keeping that community alive by the skin of your teeth and the will of your heart. And I guarantee they're not getting paid for the work that they're doing. But some of it is the lack of structured inclusive care, and it's a lack of education and health professionals. When should a queer woman restart sexual activities after a hysterectomy, after a mastectomy? Someone who has sex with women, when do they get cervical screening? Those things. I can tell you, if you ask 1,000 med students, they can tell you what the cancer screening guidelines are for bowel cancer. They won't be able to tell you that. In Otago, fun thing I learned the other day is they have halved from 2 sessions on gender queerness education to 1 in their entire course. And then, as we've talked about a lot about the racial inequalities. This is fantastic because I as someone who said, I just admitted I don't like to do data, and it's probably because I have a skippy brain, but I like having the data. I like it that other people do it because it means that it's not just I feel this. It's not just that my patients tell me this. Here is the facts. This is what happens. In someone adjusted for age, people with myeloma live shorter. The progression-free survival is shorter. their time to death from diagnosis is shorter. That is driven by less, the paper is in there, but it's driven by they get less chemotherapy, they're less likely to get an auto, they get diagnosed later, and they get diagnosed when they have more complications of their myeloma. And their overall survival is shorter. And this is terrifying because they tend to get diagnosed at a younger age. So that's not adjusted for age, but when it is, it's even worse. When we talk about the barriers and disparities, unfortunately, a lot of the information comes from the US. And I do want to say, I know that Maori are not the same as Black people, but when we talk about a lot of the racial determinants of health, they're often similar in terms of the racial barriers. So I don't believe, when I use the word race, I don't believe in race. Like race is, I don't have a race, I have an ethnicity, I have an ethnic background, but race is what society puts on me. That's how I look at it. So I'm going to talk about race very specifically and very intentionally, because I'm not talking about how people identify as themselves. I'm not talking about their family. I'm not talking about their background. I'm talking about how the system views them. And these are the problems. So you have some biological stuff. So there is probably, and this is an equity issue, not because of because no one knows. So when clopidogrel first came on the market, a whole bunch of Black people died of heart attacks after being put on clopidogrel when their stents were put in. Do you know why? Because a proportion of people from an Afro-Caribbean background have a gene that metabolizes clopidogrel quicker. It was never picked up in the trials. So there's biological differences. And when I talk to people in trials, because I get 1,000 trials across my desk, I say, well, how are we making sure we've got enough Maori? If this trial's in New Zealand, there should be this percentage of Maori people in the trial. It should represent the amount of people who are Maori who have myeloma, for example. And they don't do that. It's not specified for. We should be enriching for populations that have poorer outcomes. We do it for biological things. We do it for TP53 mutations. We enrich for those populations. We don't enrich for others and every time I challenge, I get these really wobbly answers back. Oh, well, it's difficult. And it's like, well, whenever you tell me something is difficult, all I hear is I don't care hard enough to try. I'll come back to that with gender and pronouns in electronic things. There are issues talking about in AL, hematology is not unique. We have issues. No one worked out that methotrexate metabolism was different in African Americans until very recently, and we've been using methotrexate in ALL procedures for more than 50 years. So some of it is biological, but we don't know about all the things that are biological. So we're not looking, we're not interested, we're not spending the time, energy, and resources working out, is there genetic differences and what can we use instead? Do we need higher doses of methotrexate? Do we need different monitoring of this? What are we going to do about that? Some of it is comorbid conditions, largely, of course, driven by the social determinants of health. And those things are understudied in trials. And I want to be on your trial, and we need to talk about it. I want Southern to be doing that because it's incredibly important. And some of it is to do with clinical trial participation. So everyone's heard of the Tuskegee syphilis study, where they just decided not to treat a bunch of Black African men who had syphilis, just to see what the natural history of syphilis is, as if we didn't have untreated syphilis for centuries beforehand. Because of those studies existing, there is perception on both sides about clinical trials. So there definitely are people from racial minorities across the world who've heard about this. If you talk about so I trained in Australia. You can talk to First Nations people who will talk about who are alive today, who have family members or them themselves in their youth who were experimented on. So there is living history of people having problems with clinical trials because of living trauma. Also, white people get really nervous that they're going to think badly of us if we set to put them on a trial. So it works both ways. And there's a lot of things. I'm really a fan of prompt questionnaires for this kind of thing. So you can give patients the ability to ask questions, to ask about these things, to give them agency and opportunity and the ability to say no if they don't want to do it. But There's interesting thing. There's a really interesting study that says if you have one Black physician in your practice, the health of every Black person in your practice improves. And so what it tells me is we need ethnic and all of the diversity in our healthcare profession, in our nursing profession. We need to not have one token person. We need to have many voices. I always think about the Mattel Oreo Barbie thing. So Oreo is a derogatory term for someone who's Black on the outside, white on the inside. So Mattel got in partnership with Oreo and they had Oreo Barbie, and then they released a Black Oreo Barbie, not realizing because no one in the room had power to say that. And that's the problem. So sometimes the things aren't deliberately racist or sexist. It's just that there's no one with power in the rooms to say, hang on, have you thought about this? It's same with leukemia. Mariam Pacifica. There's particular issues in leukemia. There's excess mortality. Some of it, as I said, is probably related to some biology that we don't know about, but also getting access to a transplant. So having a person who is Maori actually finding an unrelated donor in our registry is very difficult. One of the things that's really fascinating is if you look at donations, not as a health outcome, but as a product that you want to sell people, you can actually determine that most of the reasons why people don't donate is like they did this in Australia and they thought what we'll find, it was particularly about sickle cell anemia, and thought what we'll find is that people have magical thinking around blood. So I want my blood back because I am this ethnic, on my cultural beliefs are that blood should come back to. So if they don't use my blood, I want it to come back to me. And that's obviously not possible in a blood service. And it turns out that's almost never the reason. The reason is people who don't feel included in society do not do altruistic things for that society. And that's the problem. So what you'll find is if a person in a community needs a blood donation, there'll be a whole bunch of people who'll be like, oh, that's helping someone I know, someone who I have a connection with, even if it's a distant connection, and you'll have increased donations in that community when someone explains to them, actually, this is why we need your samples, your blood. So those are the things that on a systems level are a problem. This is really fascinating, but there's not much data done on this, like pretty much everything to do with trans health. There's an increased rate in lymphoma from trans. It goes both ways, so it's not hormonal, and we don't know why. And I'm not doing the study. Barriers to health. So there's a fear of mistreatment, and this is one of the things I thought was. So this came from oh gosh, I've written it down. No, I didn't write it down. Why would I write it down? That would be useful. There was a rainbow person's survey that they did. So these are people who identify as Maori and Pacifica and LGBTQI, and what their experiences have been like of their unfair treatment. And you can see the day-to-day, do you think you've been treated with less courtesy is incredibly high. Are you followed around in stores? Do people act like they're better than you are incredibly high? Why are you engaged? Like, would you engage with somebody who treats you like they think you're a criminal, who thinks they're better than you? Like, well, you wouldn't engage with that person. I wouldn't engage with that person. Why are we expecting other people to? There's issues, 14%. This almost made me cry. 14% of people in the Pacific Rainbow community had experienced some sort of conversion therapy. I grew up Christian. I can tell you that that's 100% true in like the Seventh-day Adventist community. Like it's not called conversion, but it is like, and I had a fun thing I learned the other day is one of the endocrinologists in Dunedin, and no one will tell me who it is, refuses to prescribe gender affirming care. So if the other two are away, there's no one to prescribe that care. Yeah. I have, of course, like I always do with any presentation, is I've skipped to some of the bits when I was talking about other things because I never read my own slides right beforehand. So I've talked about how the medical schools have problems, and it's why I'm so grateful for this talk today, because we are talking about these issues, and things thrive with the lack of the lack of light on these issues is why they continue to thrive. People who are looking at gender affirming care don't get told about sperm storage, for example. So, they might want to have kids one day. They don't know you don't know who their sexual partners are going to be. Maybe they do need the sperm for their partners. Sexual health after hysterectomy and mastectomy. And one thing I did miss is anal cancer screening in men who have sex with men due to high rates of HPV is not routinely done. There's issues with technology. So let's say you're in your GP office. So when I go to the GP, she does, and I do my little well woman's check, which is code for PAP and for me diabetes. They go, oh, your last PAP was 5 years ago. If you change my sex or gender to male in the system, that prompt goes away. And there's sort of this assumption that women who have sex with women or trans people have only had penetrative sex with a member of, so then they get missed and they don't get their cervical cancer screening. And we all know that cervical cancer screening saves lives. And then the next thing is data gaps. So as you've seen, there's almost no data in my study because the data for LGBTQ subpopulations almost doesn't exist. No one's asking the questions. And also I think I would suspect, I must admit, before I was out to my very traditional family, I don't know, I would have ticked that form. Because then what if someone said something to my mom when she was there, and oh God, 20 years later, I'm anxious about it. But there's also issues with so my big issue, I have a trans patient, I have a non-binary patient who mostly identifies as male, is very male presenting, and has the most female name ever. They don't go by the female name, but our system doesn't capture that. They haven't legally changed their name, and they haven't chosen to change the name on Health Connect South. I have suggested to them that they do that because my queer dog went off and I was just like, hey, what do you like to be called? The third time I met them, because I met them when they were a teenager, and they told me that. The problem is when my nurse goes to weigh them and call them in the clinic, they're going to out that person as a trans person. Out of no malice, out of no intent, because our system has set my nurse up to fail. I cannot get pronouns. I have been fighting for pronouns in HCS for 5 years. I got told it's very difficult, which again, as I've said, I think whenever someone says that to me, I think you don't care enough. And my response to that when they said it to me was, that's interesting because a week after the COVID vaccines came out, I had that information on the landing page for my patients on HCS. Surely that takes a lot of informatics because that has to go through the immunization nurse database, and then that has to go into something else, and then it has to be pulled into IPM and then pulled into HCS. So there is 4 systems that have to talk to each other for that information to come to me. And I can't get what in your intake form, tick your pronouns, put into HCS. So again, if anyone wants to complain about that, please do, because I feel like I'm complaining constantly, but if it's not just me, I'm a little bit of a squeaky wheel when it comes to that stuff. And sometimes I kind of wonder if they just think it's me who thinks it's terrible. And I think the other thing is sometimes when we're younger in the healthcare system, we haven't seen the bad things that have happened before, and we haven't heard the stories. So we don't know what we're fighting against, and we don't know what could potentially trigger people. And so that's one of the other things. And then we also have issues with geography, which I think lots of people have talked about. There's privacy concerns from an LGBTQI thing. They're afraid that people will say something. They're afraid that their data will be hacked, that they'll be outed. Not everyone is out at work. They're concerned about who has access. Is their mom who kicked them out going to be able to get access to their information? They're afraid of misgendering. So we had a terrible thing that happened with HES when oh God, what's it called? SIPICS. When SIPICS came out, everyone's data got reset. And a whole bunch of people in the gender affirming care clinic in Dunedin got their sex changed back. No one did that. Like no one went, oh, she's fucking female. Like it just, the system went, you came into our service as a female, therefore you are a female, and reset everybody. It also reset phone numbers and addresses and all of the other things. But that's very painful. Like, oh, you have my old address, I can fix that, is very different to Mrs. Blah, can you come in? And then they're also afraid of disclosure without consent. How late am I running? Okay. Let's talk about culturally competent care. So basically, I kind of think of this as how to be a decent human. My goal in life is to be the least amount of jerk. I'm Australian, so it's a C word, but least amount of jerk to the least amount of people is my goal in life. So, and I think this is one of it. But you also have to, you can't go around blind. You have to go back and look at the people in front of you and what they've experienced and understand that as well. So you have to have some sensitivity to the patient's belief and ensuring that their care aligns with their values. And that crosses everything. Like there's a lot of things in equity that are very specific to the populations that you're talking to, you know, culturally sensitive language, having written materials in the patient's language that they can read, things like that. But there's some stuff that's just everyone should be treated like the unique and special person that they are, and you meet them where they are. And that they can access the healthcare system. I'm really big into empowering patients so that they can be actively involved in their care, because that's really important, is what do you need? I'm not telling you what you need. You know, you can tell me what you need too. I can say, hey, lots of people have struggled with this. Do you need help with it? But they also should be able to say to me, I'm not getting the care that I need. This is a problem with me. They almost never tell me, actually, to be fair. They normally tell my nurses, which is why I'm so grateful I have the amazing team I have around me, because they often don't tell the doctors, which is one of the things I struggle with. I'm like, I'm nice. Like, you can tell me, I won't get mad. So, you know, it's about this holistic Maori health model when we talk about ethnic. I'm going to skip through this because I feel like we've had a fantastic talk about, and someone who blew into New Zealand 5 years ago is probably not the best expert on all of this. But I think the role of I don't, when I came to New Zealand and I heard the word whānau, I felt found, because that's how my family operates. When my grandmother was dying, there were 6 family members who looked after her around the clock. That's how we work. And so the idea that one person is the center of a healthcare journey is sort of true, but it's actually not, because actually a cancer diagnosis affects, it's a stone in a pond and it ripples out, and there are people closer and further away, but it affects everybody. And we know that when we involve the whānau, and when I talk to people, I love the word whānau. I didn't have that word in Australia. I love it, because when I say that, I don't mean who's married to you and I don't mean who's related to you. I mean who shows up for you. Who are the people that you call when you're sick? And I love that all of that is in that word, because I can use that when I'm seeing people. So that's one of the incredible things that I just think is that we need to be looking at. We need to be looking at using language, using decision-making tactics that foster those partnerships, not just with the patient, but with their with their people, with the people who turn up for them. The other thing, I'm going to talk now quite a lot about language, because I think language is important. My dad is a linguist, and I used to get bored and read his linguistic books, which just shows you that if you leave me in a room with a book, I will read it. We have to be really careful about the phrases that we use, that we're not making up. We're not assuming things like that. So we don't say when the older man, the 70-year-old man comes into clinic, oh, who's your missus? Where's your missus? Because that assumes a lot of things. If we make an incorrect assumption, we put the patient who's already got cancer and is in a new environment and is already scared, we put them in the position of having to say, either go, I can't deal with this right now, and I'm just going to let them misgender me, misassume me, miss whatever. They have to correct you. And now they're like, that person is going to deliver me healthcare, and now I have to tell them that they're wrong. That's stressful. So we have to know how to ask open questions. So instead of saying, are you a Miss, Mr. or Mrs., which assumes that they have gender identity and stuff like that. And also, I have a bunch of people married who kind of hate the like Ms., Miss. One of the nice things about becoming a doctor is I got away from all of that. You can say, what is your title? the way I introduce myself, and I'll continue to learn and grow. I say, hi, I'm Fionnula. I'm your hematologist. My pronouns are she or her. What do you like to be called? That's what I say. I don't specifically ask people their pronouns because not everyone wants to be out to you at the minute that they meet you. So I invite it. I don't request it. I think a forum is very different to a direct question. So that's how I do it. So I say, this is what I go, that's what I say. I also say, I don't necessarily say my gender identity or my things, but there are times when that actually is useful. Like when I was talking to my patient who is clearly non-binary and like had this name that I knew was not working for them on the record. And I said, look, I'm queer. How do you identify? Is the name not working for you? Because at some point I just had to be like, someone has to do something. Like we're clear, like you clearly are not identifying. This is clearly not working for you. But I'm not out to all of my patients. I mean, I have a badge, but that's like, I'm not like, no one deserves anything about my existence. But there are times when you have to make yourself vulnerable to invite that in. The other thing is I don't ask about partners. I ask who turns up for you. I ask who are the people that you would call, because some people are recently divorced, they're bereaved, they're whatever. Some people are single married mothers, like they are doing everything and it's their girlfriends who turn up from them and not their husband. Like those people exist. So I say, who turns up for you? Who are the people you want in the room? We're going to have a difficult conversation. I want someone who's going to remember and who's going to remember your questions. Who do you want in the room with you? So I don't talk about partners because I find that for lots of different reasons. It also assumes that people aren't polyamorous relationships. There's lots of things. If you don't know, because like I had to Google demisexual a while ago because I was like, oh, that's coming up on my feed a lot. What's that? You can say, thank you so much for sharing that. I don't know what that means. I can look that up. But if you've got the time and energy and you want to tell me what that means for you, I'd be welcome to hear it. Because you don't have to know everything all the time. If anyone wants to know, demisexual is people who only have sexual attraction to people they're romantically involved with. And I said that to someone and they went, isn't that everyone? I'm like, no, it turns out some people see somebody and they're like, would hit it. Like, and hi, welcome to being queer. Because whatever you experience is normal for you, right? So look, where do we go from here? Inclusive practices and language specialists. So we play a pivotal role in implementing inclusive practices. We use inclusive language. We use gender neutral terms. We allow patients to share their preferred name and pronouns. We have to engage in the training. There's a new training module up in Southern. I don't know. It's apparently it's apparently nationally available, but I haven't checked. It literally came into my inbox 2 days ago. I would love to have some rainbow cancer stuff happening, some support groups, some things, some virtual things. That means this is a safe space. You don't have to go in and be like, well, I have breast cancer and I'm queer and oh no, none of you are either. And now I feel really uncomfortable in this space. And I'm not talking about my husband, I'm talking about my wife, I want gender neutral forums. My mom has some friends who are incredibly right wing and they have things like, oh, you can't use chest feeding and chest reconstruction. I'm like, no, all it is you can call it your breast. Your child can call you mother and not birthing parent. It's fine. It just means more people are allowed into the room. Like I said, I think our systems need to be set up better. The other thing I'd really encourage people to do, because now I'm realizing I'm almost at the 45-minute mark, is the implicit association test is available through Harvard University. It will destroy you. Warning, trigger warning. It basically gives you a short amount of time to answer questions and it will reveal to you how biased you are. It is fantastic to do because if you don't know about a bias, you can't compensate for it. We need to also I think we need to have clear anti-discrimination policies. One of our nurses got a haircut, which led to another nurse who was, thank God, not one of our in the wards, asking about her sexuality and the sexuality of her partner, which person I just met. And I was just like, yeah, that kind of stuff is not okay. The welcoming environment. I think someone said that like not all our patients are welcome, and I think that's really true. We've got this fantastic new carving that I think makes our Maori patients like gives them like it's this beautiful Maori carving that's been put in our thing. I think it shows that we're a space. We have nothing for that for the rainbow community. We need to be. I was a bit disappointed with my. I was 2 years in New Zealand before I learned about the importance of tissue and having the discussion about returning that to a patient, which I felt like, and I discovered that on my own. And I was like, God, that would have been really useful when I first moved here. And I went to the cultural training section because I take bone marrows and I take blood. And I could have had that conversation and it would have been fine and easy. And most people are okay with it. When I discuss it now, they're fine with it. And when a Maori patient loses their hair, we can do something about it. But I was completely ignorant. So I do think we need to sort of share these things. The collaboration with community groups. When we're doing things, we need to be involving community groups from the beginning. We need to build it from the get-go. It needs to be built with our communities in mind. And the other thing I think that is incredibly important for change is having a diverse workforce. Because if the powers in the room are still the powers in the room, it doesn't matter how many of us are down here. Like we need to be up here as well. Like as you like pull as you climb, so pull other people up behind you, advocate for change. Every single annoying email you send about the fact that these things don't exist means it continually gets put on someone's radar. So I have put in some amazing strategies. I don't think it'll surprise anybody that the amazing books that are available are all nursing books, which says a lot about my profession and fortunately a lot of good things about yours. But these are fantastic resources for non-binary and trans health. And I think I have like a minute or two if anyone has questions. Yes.
Sorry. Is it on?
Yeah.
Sorry, I was just saying the discussions I've had with people around medicine and the need to perhaps in emergency situations or other situations to understand that somebody had a particular sex that they were born into, but then have chosen the importance of expressing themselves in a different way.
Yeah.
And how do we respect the privacy and the choices that people make?
Yeah.
But also understand the acuteness of sometimes knowing that.
Yes. I think it's a discussion. I 100% agree. Because like if you come in with a chest infection, it's none of my business. If I do a karyotype on you and I go, oh shit, we're going to have an awkward conversation. And then you go, which did happen to me once. And they were like, yeah, I know. Okay. There was someone who had it was not, again, none of my business. Like except for the fact that I was like, well, now I know something about you that you should know, that you have two X chromosomes, an XY chromosome, but you're actually, and that was somebody who had transitioned, but just didn't think we deserved that information. I think there's certain information that is in certain times when it is important. For example, we talk about cancer screening. It's important, but it's also not important for 1,000 other things. It's about consent. It's also about saying where things sit in the medical record. So, person whose medical record says that they're Bob, but they go by Jane, for example, I want that on the nursing sheet. I want everyone to be like, no, we call that person Jane, and we use she, her pronouns, and that's what we do. But on other times it's not, because the fact is coming. I had this magic idea that I would come out and everyone would that I would never have to do it again. I had the awkward conversation with my parents, and then I go like, finally, I told my brothers who are like, yeah, cool, whatever, because they're like Gen Z, and but the fact is you're coming out constantly to people and you have different levels of comfortability when you're coming out. So if I think we need to create a workforce. And again, it comes back to we need to get rid of the fence. We need to come to a workforce where it's like, yeah, whatever, like not whatever, like it's as useful as your address is, because it tells me something about you, but it doesn't affect anything about how I see you. It tells me, oh, you live in Oamaru, and therefore I know that this is the service that you need. But we're not there yet. And I agree, it's really difficult because like people get to choose who they tell. So it's about a conversation about saying like, hey, you need breast cancer screening. because your parent has breast cancer, or that's the only thing. So sorry, not a simple answer. No. I think the only people who give you simple answers are lying and politicians. They're either selling something. Anything else?
Taking just made me think like,
Yes.
so if you haven't read it, it is so when you were talking
Yeah.
this is it, this is the stuff.
This is the stuff.
It is
Yeah.
It's a fantastic book.
It is absolutely fantastic. Yeah. Yeah. All right. I'll leave. But thank you very much for inviting me. And I want everything that's been talked about so far. So like I want the hospital of the home. I want the oh my gosh, this conference.
Okay. So